I'm Chris Fanta. It's my pleasure to welcome you to Asthma Grand Rounds, and a special welcome to those who are viewing from their desktop at home or at work via our live webcasting. And I just want to take 1 minute to share with those who are watching by live webcasting how you might submit a question to our speaker at the end of the presentation. And the slides are illustrative here. You will have clicked on live to enter the program, and perhaps you can make it out here. At the bottom there's the, thank you very much, the icon. If you click on that sort of cartoon thought icon, up comes the ability to ask a question and then submit your question. And we welcome your questions at the end of the presentation. So it is a great pleasure for me to have as our speaker today Dr. Benjamin Medoff. Many of you know already. He is the Chief of Pulmonary and Critical Care Medicine at the Massachusetts General Hospital. He's the Associate Director there of the Center for Immunology and Inflammatory Diseases. And he's a leading investigator in the area of T-cell biology and its role in inflammatory lung diseases. And so we're very pleased to have him here today to talk to us about T-cell trafficking in allergic asthma. Dr. Benjamin Medoff.
Thanks, Chris. And thanks to the Partners Asthma Center for this invitation. So it's a real pleasure to talk about T-cell trafficking in allergic asthma. It actually was the very first project I was put on when I joined the Luster Lab 13 plus years ago. And it's continued to be a focus of my lab, and actually for the Center for Immunology and Inflammatory Diseases. As I'll share with you, it's quite a large group that focuses on T-cells and asthma and allergic disease in general. And I will talk about specific stuff we're doing, but a lot of what I'm talking about is a project that is investigated by many, many people, as you'll see by the end. So I will be the representative of a very large effort led by Andy Luster, who deserves a lot of the credit for orchestrating this for the last 10 plus years. So what I'll try to do today is just get us all on the same page with some definitions and some assumptions that we make in investigating T-cell biology in allergic asthma. Review very quickly our view of the sort of T-cell-centric view of the pathogenesis of allergic asthma, and then just some mechanisms of T-cell accumulation in the lung. Then I'll present a paradigm or model for T-cell accumulation during asthma that we've developed over the last 10 plus years and have proposed. I'm not sure it's right, but it certainly helps us frame our research questions. And at the end, I'll just when people are getting bleary-eyed from all the mouse studies and other things, I'll shift gears to our more translational human studies, which hopefully will be of general interest to both clinicians and researchers, and what we're doing in studying the inflammatory process in humans using segmental allergen challenge, and then linking that to airway physiology. That stuff is all novel, new stuff that we haven't published, so be interested in getting some feedback. You don't have a pointer, Chris, do you? Or should I use the mouse since it's the mouse. I'll use the mouse, okay. So for this audience, I don't need to spend a lot of time talking about the pathogenesis of asthma. I think we all accept that asthma at its base is an inflammatory disorder of the airways. We probably shouldn't use the word disease. I think it's well understood now that it's more of a syndrome or group of disorders, lots of different flavors. But I think for most cases, they share that common entity of an inflammatory cell infiltrate. I don't get the mouse up on this screen here, unfortunately. So, an inflammatory cell infiltrate that's associated with phenotypic changes that give us the symptoms that we know and love as asthma docs, but swelling of the airway, mucus production, airway remodeling with thickening changes like that, and then twitchy smooth muscle cells that may also thicken in addition, that give you your airway obstruction, cough, etc., symptoms from that. So if we accept that asthma at its core is a chronic inflammatory disease that then then over time leads to these phenotypic changes that we know, or at least is associated with that, then the question is what stimulates this inflammatory process. And as of late, this is from a review that Sally Wenzel did, looking at all the different phenotypes of asthma, and I think I certainly accept there are different flavors of asthma and phenotypes. I don't know if I totally buy all the different types they're doing here, but it certainly is a work in progress. And I think what you can see is, although there are many different types, I think the great majority, it's fair to say, of the phenotypes fit this allergic type disease. People who have a history of allergies, have triggers, environmental triggers that stimulate these things. And I think for the most part, the allergic asthma we see is Th2 type mediated, meaning it's eosinophilic. Not all of them, and whether it's 50% or 80%, I think we can debate, but I think that's a good part of it. And given that this is the majority of cases, that's really what we've studied in our group, is the allergic basis for asthma, with the caveat that we're obviously missing different flavors here. I think the preponderance of data really seems to support that the inflammation that results, certainly in the allergic types, is a reaction to an environmental antigen. House dust mite, cat dander, et cetera, that we would call an allergen, but some type of reaction to this when the subject inhales that or is accompanied to that. And we see that in our human studies, and people have shown over and over, if you stimulate with certain peptides, you can elicit the inflammatory reaction that's characteristic of asthma. And this is likely driven by T cells. And we know this from the general understanding of the immune system. I'm not saying B cells and macrophages and epithelial cells and eosinophils are not important. I think they're critically important. But I think at its core, this is going to be driven and orchestrated by a T cell response to these antigens. And I think even the other phenotypes, which may result from maybe a Th17 type inflammatory reaction or Th1 type reaction, we certainly see people who all the world look like allergic asthmatics, and we challenge them with a little allergen, they get a neutrophilic response and high IL-17. I still think that may be relevant to T-cell driven processes. So understanding that T-cell driven process, I think, is pretty important. Now, why Th2 cells? Because that's really what we're going to spend most of our time on. Well, I think there's very good data out there that Th2 cells and their cytokines can be found in the airways, certainly of allergic asthmatics. That this phenotype, and there's old data and now newer data, predicts the response to therapy, whether it's inhaled therapy, steroids or anti-cytokine type therapy like IL-13. And certainly in mouse models, if you transfer in Th2 cells, that's enough to recapitulate allergic airway inflammation. And if you don't get Th2 cells, whether it's by knocking out a transcription factor or other things, well, that prevents the development of the asthma phenotype. And so we've always been interested in mechanisms controlling Th2 cell recruitment into the lung. I come from a chemokine lab, that's where I trained, and so that seemed like an attractive place to look. And certainly pharmaceutical companies for years have tried to develop specific agents that would inhibit chemokines or their receptors, the things that direct Th2 cells into the lung. But what I hope to touch on and especially get to at the end here, how that really is not as obvious as we had once thought for several different reasons, and may not actually be the best way to approach therapy in this. So the T-cell centric view of asthma is that this allergic asthma results from aberrant T-cell activation. And basically, you have all these different antigens floating around that we're constantly inhaling. And for most people, this results in either no recognition or, probably more likely, your immune system is said, don't worry about it, is told, don't worry about it. It's something you should just tolerize. And either the T cells are rendered anergic or regulatory T cells take over and suppress any immune reaction to these antigens, whether it's house dust mite, cat, pollen, or cockroach. However, in asthmatics, probably due to innate immune activation, whether it's in epithelial cells, dendritic cells, or macrophages, for some reason, maybe the environment, maybe the genetics, probably a combination of both, some people see these antigens here, and the intrinsic protease activity or other activities of these antigens stimulates an immune reaction. And the T cells that normally would say, not be worried much about this, somehow think it's an infection or a parasite or something, and then are told to react to it. And so what happens is the subject is sensitized, and then every time it's exposed, because the T cells contain memory and tell the B cells to make IgE antibodies or whatever, the person, whenever they see that, is going to have an immune reaction. So if we break this down based on multitudes and multitudes of studies and then greatly simplified here, what's happening during the development and exacerbation of allergic asthma is you have your antigen come in. There's first a sensitization process that occurs, and maybe this is early in life when the subject is exposed to cat for the first time or house dust mite, et cetera. And whether it's interacting with epithelial cells or dendritic cells, there is a liberation of cytokines that matures the dendritic cells, which then migrate to the lymph node, present antigen, and tell this T cell to turn on, thus priming it for activity. If these are not matured, you may get an allergic reaction, and the T cell is told to ignore that. Why this occurs is obviously a place of great interest for a lot of different groups. But needless to say, I think this occurs. Your T cells primed, and over time, memory T cells then come, populate the lung, populate the lymph node, and sit there and wait for antigen to recur again. At the same time, these T cells orchestrate IgE production, maybe prime macrophages and other innate immune cells, such that when antigen comes again, there is a cascade of reactions that result in liberation of all types of chemokines as well as other cytokines and mediators that then exacerbate the inflammation or the process there. At the same time, antigen is brought back into the lymph node, presented to T cells. These T cells expand. I have both Th2 and Th1. These then circulate into the blood and then come back into the lung, amplifying the response. And here I have even Th17 and maybe NK T cells, just showing the complexity that may be there. Regulatory T cells are also brought into this system and work to suppress this response, but probably the ratio of the regulatory and the effector process is such that it favors the inflammatory state. This then brings in EOs, bringing the eosinophilic, and eventually all these mediators that are produced lead to mucus hyperproduction, smooth muscle cell hypertrophy, and airway hyperresponsiveness. And that's basically the exacerbation phase and the inflammation stage. So how do T cells move? Well, there's a whole bunch of chemoattractants, and this is my only slide on chemokines today, although we'll talk about the T cell trafficking. There's something on the order of 50+ chemokines with their receptors, another 20+, as well as peptide chemoattractants and lipid mediators that can induce the movement of leukocytes into the lung. And these can be during inflammatory states or also homeostatic states. So if you look at just T cells and the process they do, under the non-inflamed state, T cells are circulating in the blood, move into lymph nodes through the high endothelial venules, where they survey, look for antigen. If they don't see it, they circulate back out. And this is orchestrated by a bunch of different signals, including CCR7 and SLC and S1P, which orchestrates the exit of T cells out of the lymph node. And if they don't see antigen, this process sort of circulates. Within the effector organs, like the lung, there are memory cells sitting, but naive T cells don't normally go in there. Now, if they do see antigen, you can get activation and polarization of the cells. Here we have Th1 and Th2. They exit as effector memory cells or effector cells, go out into the circulation, and then if there is areas of type 1, Th1 type inflammation or Th2 type inflammation, they will be brought into those regions, see what antigen is there, as well as call in their friends, the eosinophils or neutrophils, and orchestrate an inflammatory response. There also is a process where they exit and sort of help to resolve the inflammation through afferent lymph that I won't be talking about today. So what's interesting is that when you look at the profile of chemokines and chemokine receptors in these different inflammatory situations, you can see distinct profiles. So in Th1 disease, we see a lot of CXCR3 and its ligands, as well as CCR5. Th2 disease. Got to make sure I'm pointing to the right one. You see CCR4 and CCR8 as well as others, maybe CRTH2, and its associated chemokines and so on and so forth. The interesting thing is one of the problems I think with trying to use these as therapy is usually it's not single. There's multiple chemokines and chemokine receptors. It's a redundant system. So to just inhibit IP10 or just inhibit CXCR3 may only do a partial job. The other thing that I think has complicated this is the realization of the regulatory T-cell component to this, and the idea that not all regulatory T-cells are the same. So there's Th1 type flavored regulatory T-cells and Th2 type that are recruited through the same mechanisms as you see with the Th1 or Th2 effector cells. So if you block CCR4, let's say, to reduce the number of Th2 cells, you may also block the regulatory T-cell recruitment in addition. And if it's the ratio of these that's important, more effectors leads to inflammation, more regulatory T-cells leading to suppression, you may not influence the inflammatory state as all. So we've, in our most recent human studies, and I'll hopefully have time to touch on this in the end, really have started to look at the mechanisms bringing both of these cells in that ratio, and I'll show you some interesting stuff. I want to fairly quickly move through our paradigm for T-cell recruitment, our Th2 cell recruitment in asthma. And this has been years and years of work with lots of people, more than just me. And I'll try to mention everyone, but I'm sure I'll drop some people. And it really started just by looking at different chemokine receptors and then sitting down as a group and trying to pull this together. I have to give credit to Andy Luster for really masterminding this whole process. We're not sure it's right, but it seems to make sense and tells at least a nice story. So you know, what I'll talk about is once you have exposure to antigen, this is in sensitized individuals, right? You've already established your T-cell responses and have IgE. There's an initial mast cell reaction, and this we know very well, that causes the initiation of Th2 cell recruitment. A propagation step that probably has more to do with the nature of the antigen coming in, whether it's toll-like receptor stimulation or other aspects of it. And then what we think the most important aspect is the amplification step, which really brings in the majority of the Th2 cells. And what I won't talk today too much about is the resolution of T-cell leaving, although we'll talk about the regulatory T-cell component of it. So the initiation step really came out of work that I joined in with Andy Tager on leukotriene B4 receptor, BLT1. And it was well known at that time that leukotriene B4 through its receptor was an important stimulus of chemoattraction for granulocytes, neutrophils, and eosinophils. But what Andy had showed, as well as with Uli van Andrian, is that it also stimulates chemoattraction of effector T cells, both Th1 and Th2 cells. And to make a long story short, after a lot of work, what we were able to show was that in the asthma model, and this is a mouse model where we basically, for these mouse models, we sensitize the animal to a foreign protein. We usually use ovalbumin, but you can use cockroach, you can use house dust mite, et cetera. But after sensitizing the animal, you challenge them in the airways. And although I hesitate to call it a model of asthma, it does give you an allergic type inflammatory reaction in the airways that mimics the biology, at least, of the human state. And interestingly, when we look at the full model, we don't see much differences. But when we looked in the early stages, knowing that maybe leukotriene B4 was made by mast cells, we saw a profound defect in the number of T cells coming into the airways with one challenge or greater challenges or two challenges that then went away with this. And this really made us think that the initial recruitment of T cells may be mast cell mediated and what we called the initiation step. And we subsequently have shown that if you put immune complexes down and stimulate mast cells, that makes a strong chemotactic gradient for effector T cells that if they're BLT1 knockouts doesn't occur. So the first step, this initiation step, is really mast cell mediated, probably leukotriene B4, maybe other mediators such as CCL1, which works through CCR8. That brings in an initial push of memory Th2 cells that may be circulating or from lymphoid compartments in the lung. The next step, propagation, really came from some of our initial human studies. We started doing segmental allergen challenge in humans. I'll talk a little bit more about it later, but basically in the right middle lobe, we just instill a little bit of cat allergen or house dust mite allergen in sensitive subjects. Come back 24 hours later, you get a very localized acute reaction in that area with lots of eosinophils. And we looked at the T cells that we're bringing in, expecting to see all types of Th2 type inflammatory chemokine receptors upregulated. And early on, we also saw a lot of Th1 and also Th17 chemokine receptors, CXCR3 and CCR6, or at least evidence that those were being tickled. And when we looked at the ligands for CCR6, which is CCL20, or CXCR3, which is MIG here, IP10, and ITAC shown here, we saw upregulation of those chemokines in the BAL, or the lavage fluid, compared to pre and post here. And was kind of intrigued by that. Why are we seeing Th1 in these allergic? We certainly saw a lot of eosinophils and Th2 cells coming in. And really what was the thought process behind it is that these allergens have LPS. We try to use as clean stuff as possible, but maybe other toll-like receptors, and all these receptors stimulate these, this liberation of chemokines. So the propagation step, we think, which is probably macrophage mediated, or maybe other myeloid cells in the lung, through antigen and possible toll-like receptor stimulation, causes liberation of more Th1 and Th17 type chemokines that may assist. And even though these are Th2 cells, they do express low levels of these other chemokine receptors, or maybe bring in some Th1 cells or Th17 cells into the mix. So we called this propagation. Again, in that early stage, this is still within that first day or so after exposure. The next stage, which I'll spend a little more time on, the amplification stage, had more to do once the Th2 cells are there and they see antigen, they start putting out Th2 cytokines like IL-4 and IL-13. And we thought that this maybe amplified the process that occurred there. And a lot of the work that supported this had to do with looking at the transcription factor STAT6, which is a master regulator of Th2 cells. Mice with knockouts of STAT6 don't make Th2 cells very well. And if we transferred in wild-type Th2 cells into these animals, and this was work done by Anuja Matthew and follow-up work by Zamina Mikak and the Luster group, if you transfer in Th2 cells into these animals, you don't overcome the defect in the recruitment of these cells or eosinophils into the airway. So you need STAT6 in cells other than Th2 cells to restore the asthma phenotype in these mice. And if you look at the chemokines produced here, this is a little hard to read, but the Th2 type chemokines are dysfunctional here. And I'm sorry, I just can't see well enough to point to them. But CCL17, CCL22, which are important, Th2 type chemokines, the ataxins, all were impaired in these STAT6 knockout mice, just didn't go. The STAT1 knockout mouse, which is a master regulator of Th1, had the opposite. It was the Th1 chemokines that weren't upregulated, and they have a defect in Th1 type inflammation. But you needed a cell in the lung to have STAT6 to respond to these cytokines and restore the full asthma phenotype and make the chemokines needed to bring these Th2 cells into the lung. So our model was, you have these cells brought in by the propagation initiation step. They make IL-4, IL-13. There's some cell in the lung that in response to this is going to make chemokines, which then act on Th2 cells and amplify the whole response. And you can see how this then starts to rev up and bring in and accelerate the process, and also bring in the eosinophils that we know as the real end point marker of allergic asthma. So what is that cell? And that was work that I started in the lab a while back, published back in 2009. Well, the first thing we thought was maybe it was the epithelial cell. There was a lot of data about epithelial cells making chemokines and being involved in these processes. So we obtained a mouse from who made this mouse? David Earle at UCSF, which expresses STAT6 in the epithelial cell line, but is a knockout everywhere else. And when we use this mouse in our asthma model with doing an adoptive transfer model, we were unable to restore the recruitment. So it wasn't the epithelial cell that was making it. If we looked at the chemokines, as you can see here, it looked maybe a little bit better than the STAT6 knockout alone, but the epithelial cell having STAT6 was not enough to restore this phenotype. Interestingly, mucus production was restored in this. So they make mucus, and seem to have those aspects of it, but they don't recruit eosinophils, and they don't make the chemokines necessary for Th2 cell recruitment and don't have that amplification. So then we wondered about myeloid cells in the lung, and what we did was a fairly straightforward experiment where we just did bone marrow transplants in STAT6 knockout mice, putting in either wild-type bone marrow, RAG knockout bone marrow. Now these mice don't have T cells, so this will be T cell independent, or just put STAT6 knockout bone marrow back in. And what you can see is whether we use wild type or RAG knockout, we're able to restore the phenotype and also restore the chemokine production here, whereas the STAT6 knockout bone marrow did not. So it seemed to be a myeloid cell in the lung that needed STAT6 to restore the recruitment of Th2 cells and restore the asthma phenotype. And these mice developed, I'm not showing the histology here, prominent inflammation, eosinophilic inflammation in the lung, but interestingly they didn't get mucus. So without the airway having STAT6, you didn't get the mucus production. So we were able to sort of compartmentalize those processes, but for the Th2 amplification, you really needed a myeloid cell. And the final piece of this puzzle, we used a mouse that we could delete, made by Jeremy Duffield, who used to be here, I think, in the renal division, delete the CD11B positive cells in the lung, which are myeloid DCs. And by deleting these cells, we were able to reduce that amplification process here. And if we put them back into these mice, you can restore it again. So what we think this cell is a myeloid DC. And this just shows the chemokine data. You do get some here, but if you deplete them, it's dramatically reduced. But we think there's a myeloid DC that really mediates that amplification process. So the summary of this model is that STAT6 expression in the lung is necessary for Th2 cell and eosinophil trafficking. The restoration of STAT6 expression in the airway lining restores mucus, but not the Th2 cells or eosinophil trafficking. Restoration of STAT6 in myeloid cells in the lung restores the Th2 cell and eosinophil trafficking, but not the mucus. And selective depletion of these CD11B positive myeloid DCs in the lung reduces Th2 cell and eosinophil trafficking, but does not affect lymphocyte proliferation. I didn't show you this, or mucus hypersecretion. So putting it together for the initiation and the Th2 cell trafficking, after a lot of different work and lots of different investigators, you have your antigen come in. You have that initial interaction with mast cells that causes the initiation and early movement of Th2 cells into the lung, a propagation step that probably brings in more cells, as well as maybe Th1 and Th17 cells. And then what we think is the major component of this, a amplification step where a myeloid DC, CD11B positive, pumps out probably MDC and TARC here, the major CCR4 agonists, maybe also a CCR8 agonist that then stimulate Th2 cells. There also probably is eotaxins made here. That also may come from macrophages bringing in the eosinophils. And then the Th2 cells, which I'm not going to talk about much today, actually are called back and worked by Shannon Bromley and Andrew Luster's lab, really showing that CCR7 probably calls these Th2 cells back into the lymph node, which then helps to resolve the inflammation in the process there. What I will mention, and this is just showing that if you could somehow block these aspects, that would maybe be an effective therapy. But as you can see, it's really going to be difficult to block all these different aspects here and do this. And so it's effort targeting single chemokine receptors would have to be multiple, right? I mean, you'd need multiple things to do that. And it's also different receptors too. So rather than talk about the resolution phase when it came to the Th2 cells, what I do want to share is some work that has been done by Roshi Afshar in the CIID, looking at regulatory T cell and CCR4 control of that in the lung. And this is some mouse modeling that's been done. And in this model, you do the normal sensitization. In this case, it's ovalbumin with the mouse. And then before you challenge, what Roshi did was transfer in ova-specific regulatory T cells that she isolated from mice. So these are regulatory T cells that recognize ovalbumin and should hopefully be suppressive for this. And what you can see here is that if you just look at total cells or eosinophils or lymphocytes, if you put in wild type regulatory T-cells into these animals before the challenge, you reduce the amount of inflammation. And hopefully you can see it in the histology here very nicely. You get this nice inflammatory reaction, mucus production, and this is inhibited in mice that are given wild-type regulatory T-cells, suppressing that immune reaction. What Roshi then showed is that if the regulatory T-cells are CCR4 deficient, okay, the inflammation was not suppressed, and you got the full asthma phenotype, as you can see here. If they were CCR7 deficient, which is a chemokine receptor that preferentially moves cells to the lymph node, the reaction worked just fine. You were able to suppress. Interestingly, these Tregs do not suppress the immunization step. So you need to go to the lymph node for that sensitization to suppress. But for the challenge step, you need to be in the lung. And CCR4 on the regulatory T cells seems to be important for bringing those regulatory T cells into the lung, where they then act to suppress the inflammation that's there. We looked at these also in our humans who we've been doing segmental allergen challenge. And interestingly there, when we look at the regulatory T cells, and what we have here is the so before we give allergen, a control segment of the lung that gets diluent, and then a segment of the lung that sees antigen. And what we saw was enrichments for CCR4 on the regulatory T cells that are coming in to the lung there. So in mice, CCR4 is necessary for regulatory T cells to get into the lung and suppress inflammation. And in humans, we certainly see that the regulatory T cells that are coming into the lung during inflammation express CCR4, and much more than we see in other possible chemokine receptors. And so I think suggesting again that if you just tried to block Th2 cell recruitment with CCR4, you may also be inhibiting regulatory T cell and recruitment into the lung and affecting that process and that balance. So that's been about 10 years of work there, trying to characterize the mechanisms that recruit these T cells in lots of different people. And over the last 5 or so years, we've been really working hard to look at the mechanisms of the inflammation and linking that to the asthma phenotype. And the best way, obviously, to do that, because the mouse models really don't give you a true picture of human asthma, is to actually use humans. And so for several years now, we've been doing a project that's now funded through a U19 mechanism, and I'll try to list everybody involved, but it's multiple different groups, both at Mass General and also at Harvard Medical School, looking at asthmatics and allergic disease, at patients with allergic disease. And the main project one is looking at the allergen-specific T effector response and regulatory response, and trying to link that to the asthma phenotype. And I kind of brushed over the fact that the physiology changes and the disease problems we have is associated with the inflammation. I don't think it's that well delineated how inflammation causes the changes we see. And I think some of our studies here have brought up some very interesting questions about how those are linked. So in order to study that, the way we went about it is to look actually at 2 different groups. Rather than look at asthmatics and normals, what we became interested in looking at is allergic asthmatics, but also people who have allergies to the same antigens, but are non-asthmatic. So these are people who presumably react to these antigens, whether it's eye or skin changes or runny nose when they see a cat, but they've never reported any symptoms of shortness of breath, no history of asthma at all. And comparing the responses in the lung in these 2 things, we thought would be a good way to look at how inflammation differs and how this may link the changes in physiology that we see to the inflammation. And so we have program looking at antigen-specific T cells here and the phenotype of these cells. I'll show some of that, how they come into the lung and their level of activation, whether there's counter-regulatory mechanisms, and also looking at the ratio, which I've hinted at, of regulatory T cells and effector cells. This is very much a work in progress, and so I don't have any real answers for you, but I think understanding these differences are going to be hopefully quite revealing. These are the groups of patients that we study. Allergic asthmatics and allergic non-asthmatics. We hope to study 30 in each group. Over the last 5 or 6 years, we've now, I think, are close to 70 subjects overall. We've done segmental allergen challenge, so we've accumulated a lot. Towards this protocol, we're probably 5 or 10 in each group, maybe more, maybe 15 or so in each group. It involves, as you might imagine, a pretty coordinated effort of our allergist. Daniel Hamelos really runs the human core, has done an incredible job recruiting patients, doing all the skin testing. And then myself, Jocelyn Cho, and Scott Harris do all the bronchs. And then a slew of people do the analysis, which requires a lot of flow time and the rest. So we have patients, we can only study age 18 to 50. The FDA has limited us there. Both have positive allergen skin tests to either cat or house dust mite. And the real difference is that the allergic asthmatics will have a history of allergic symptoms and mild to moderate asthma, including a positive methacholine challenge test. And obviously can't be smokers, whereas the allergic non-asthmatics will have allergy history but no history of asthma. We ask extensively, you ever short of breath, things like that, trying to get at it, and have a negative methacholine challenge in this situation. This just shows the skin testing that we use. It's about the same for allergic asthmatics and allergic non-asthmatics. We use this to figure out the safe dose, quote unquote, safe dose of allergen that we bang down the lung. How skin testing gives you a safe dose in the lung has been worked out by other people and seems to work fairly well. We have had very few complications by putting allergen down in the lung, surprisingly, when we do it. And the protocol is pretty straightforward. We bronch these patients. They tend to be young and fairly healthy, so they tolerate it quite well. We obtain a baseline BAL lavage from the lingula, which serves as our pre in the labels we show here, or baseline. And then we go to the right upper lobe, anterior segment, put in diluent, which is basically just saline with a little BSA, and then move down into the right middle lobe, put a little test dose of allergen, make sure they don't react. We've had one patient whose airway just constricted right in front of us, but for the most part they tolerate the test dose. And then we put in a full dose. Just a couple cc's of fluid is all we're putting in there. And we sit and wedge for a little bit, make sure it stays in there, suck out what's left, and then come out. And the whole thing takes about 20 minutes or so. And then this just shows you the response we get. Here's diluent. I can't read the numbers, but usually, 5 to 10 million cells we recover in the pre-challenge. The diluent will get, a little bit more. There's always LPS or other contaminants in the scope that cause maybe a mild neutrophilic reaction. But the allergen usually gives you this brisk response with lots of eosinophils. And we've had people with 200 plus 300 million cells coming into the lung during these situations. And this just shows some older data that Seddon Thomas had published a while back when we were starting these, also done with Craig Lilly back when he was here, showing that you get this dramatic increase of total cells, and it tends to be eosinophilic as well as neutrophilic in these responses. Some really have brisk eosinophilic responses, 80+%, some or more 50%. And like I've mentioned before, we've had some who seem all allergic in the world, and you do it and you get all these neutrophils. And if you look at cytokines, they actually make IL-17 or things like that. Not many do that, but so you certainly see, even within this allergic phenotype, some variation. The subjects, the allergen dose, this is not significant. We had a few allergic asthmatics early on that had negative methacholines. I've separated those out here. But the allergen dose is about the same. Obviously, the methacholine is different by definition. These have normal methacholines. The allergic asthmatics have positive methacholines. And the lung function is really pretty comparable, although we do see a slight dip in the FEV1 in the allergic asthmatics, I think reflecting the fact that they have asthma. And may not have normal, but you're still well within the normal range here. It's just significantly different. So the real surprising thing to us, I think we all predicted that the allergic non-asthmatics would have maybe some inflammation, but not a lot. The dramatic thing is that there really is no difference in the inflammation. When you look at the cell counts and the amount of eosinophils, they get a brisk eosinophilic response. So this is the pre-BAL here, the diluent response, allergic asthmatic and allergic non-asthmatic, and then the allergen challenge segment. And what you can see, if anything here, you see more in the allergic non-asthmatics, but there is a eosinophilic response in these allergic non-asthmatics, but they report no symptoms, have negative methacholines. And that was really interesting to us and a little bit puzzling. When we looked at the T-cell responses, however, and this is just using flow cytometry on bulk CD4 positive T-cells, you do see a drop in the percentage of cells. Now this is a little misleading because there's a huge influx of cells. So the number of CD4 cells goes up, but because there's so many eosinophils, the percentage goes down. You see that only in the allergic non-asthmatics. And in fact, the number of T cells is a little bit more in the allergic asthmatics. So certainly a hint that maybe the T cells were involved in this. If we look at the cytokines that are produced, and we've profiled now a good number of these for a panel of about 50 different cytokines, interestingly, we see more Th2 type cytokines, even though the eosinophils are very equivalent in the allergic asthmatics compared to the allergic non-asthmatics. IL-4 is not much different, but IL-13 and IL-5. We also see a neutrophil chemoattractant signal also, higher levels of neutrophil chemoattractants in the allergic asthmatics. Still trying to sort that out. But certainly a signal that maybe these cells are more Th2-like, or there's more of a revved up Th2 response in the allergic asthmatics. I think the real novel component to this, and what we're most excited about looking, is using tetramers to study the CD4 T cells, class 2 tetramers that come in. For those who don't know, tetramers are these small little reagents that mimic the MHC1 presentation and bind to the T cell receptor. And by using specific peptides, whether it's house dust mite or FeLD1 type peptides, we can actually find the T cells that react to those specific peptides. So it won't obviously tell you every T cell that's reacting to the house dust mite, but specific ones that are doing there. So we can find the antigen-specific T cells, pull those out and look at them and what they're expressing within these asthmatics. And this is work, we were very fortunate to recruit Jim Moon to the CIID in the pulmonary division, who really pioneered the use of these class 2 tetramers, or at least making them better and more stable using this formulation. And having him in-house, you can see we've put him to work to make all these different tetramers so we can really, hopefully, look in all different patients, expand and look at these antigen-specific responses. So if you look, it's not a lot of events. Flow, and this is work done by Sabina Islam and Mo Ling, who's an allergy fellow, I think, coming on junior faculty soon, looking at these BALs, and you can see the lymphocyte gate here. We then gate on CD4 and CD8s. And if you look for these tetramer-specific cells, there they are in the CD4, not in the CD8 gate. So we can then take those, enrich for them, and study them using all types of mechanisms. So the first thing we thought, well, maybe there's more tetramer positive cells. And interestingly, there isn't. The allergic non-asthmatics have T cells that come in and react to these antigens that are coming in and stimulate this eosinophilic response. So they have T cells that, and we know they do because their skin and their mucosal surfaces react, but they're actually coming into the lung at the same rate as they are in allergic asthmatics. And that was a little surprising to us. What's, I think, more interesting and certainly consistent with our cytokine data is that the antigen-specific cells that are allergen-specific cells that are coming in seem to be more Th2 skewed in the allergic asthmatics. So if you look at markers of Th2 cells, CCR4, CRTH2, or S1T2 or IL-33 receptor, what you can see here, this is a busy cell. Just look at the tetramer positive, busy slide, I'm sorry, tetramer positive cells, is there tends to be greater expression of these Th2 type markers in the allergic asthmatics compared to the allergic non-asthmatics. So is it just a degree of Th2 type responses that these cells have, producing more cytokines, and there has to be some threshold that tips you over in your physiology, or is it something fundamental about these T cells that's different, that somehow stimulates the inflammatory response? Or I think we have to consider it doesn't have anything to do with this other that this licenses the patient to have changes, and it's the structural cells and other processes there that really determine whether you have the asthma phenotype. There's certainly not anything glaring like the allergic non-asthmatics don't get inflammation in the lung. They certainly do. It's a little different, but it's not much. So we've started to boil down a little more using microarrays, isolating the tetramer-positive cells and doing microarrays with Romnick Xavier over in the computational biology group. We've started. The markers are T-cell receptor signaling, asthma, and Th2 type markers. And one of these, CCL22, which is MDC, has been shown to be in Th2 cells, made by Th2 cells, and may be a marker. So pretty interesting. Certainly these cells are activated. That's not surprising. It's certainly nice that they're enriched for markers known to track with asthma, and may then show a Th2 phenotype. And we have to now start to compare this situation in allergic asthmatics and allergic non-asthmatics. Looking at the regulatory T cell is also an important component of this. Work done by Roshi Afshar and now by Lucas Faustino and Andy Luster's group. We quantitated the number of regulatory T cells that come in, and here there was also an interesting difference. More regulatory T cells in the allergic non-asthmatic group. And if you look at the ratio, it's not significant, although we're adding more patients to this, of effector cells to regulatory T cells or total CD4 cells. The allergic non-asthmatics have a ratio that favors the regulatory T cells. So maybe they're coming in, but the regulatory T cell is the real difference, dampening down the inflammation that occurs. Other interesting thing is the allergic non-asthmatics Tregs tend to be more suppressive also. So when you do in vitro suppression assays, they tend to be better at suppressing those responses than the Tregs that come from allergic asthmatics. We're just teasing this out. And then what's I think really interesting is there's different flavors of regulatory T cells, what you can see here, resting Tregs based on their CD45 RA and FOXP3 staining, activated Tregs in this window here, and then cytokine secreting Tregs, which actually are non-suppressive. And when we look at these, I'll just flip to the data here. The activated Tregs are the ones where we really see the surge in the allergic non-asthmatics. So certainly it may be fundamental differences in the antigen-specific response, or maybe it's a difference in the regulatory T cell response in these allergic non-asthmatics that just suppresses this response and prevents these things. Now in the final 5 minutes, and I'll try to fly through this so there's time for questions, I just want to talk about our last little component to this project, which is really linking this immune reaction and inflammation to the changes in physiology, airway hyperresponsiveness, and mucus. I won't talk about the mucus, although we are doing work with that. And this is old data that tried to link just cell counts to changes, and there was no relation at all to reactivity, maybe a little signal with FEV1. But it's been pretty hard to show that inflammation really tracks. You'd expect if it was totally important that, maybe there'd be a direct relationship. The more inflammation, the more reactive you are. But that's been very hard to show. The problem, of course, is how do you do that with segmental allergen challenge? Their PFTs are not really affected because it's a very localized reaction. So we utilized two imaging techniques that we're fortunate to have Scott Harris and Jose Venegas with us, who has pioneered the use of PET-CT to understand lung physiology, and then Melissa Suter. I'll show very briefly some of her work using optical frequency domain imaging. And all we do is, after doing the bronchoscopy, about 8 or 9 hours later, we image these patients with a mechanism of FDG, which does inflammation, but nitrogen-13, which allows it to track ventilation and perfusion in the lung, and also do measures of airway size with CT. And basically, we make nitrogen-13, or Scott does, with the cyclotron, which actually sits right below my office, so if I ever start to glow, you'll know why. And then they run it up to the PET-CT scanner and inject it into these patients, and it's very insoluble. So when you inject it into a patient while they're holding their breath and it gets to the lung, it immediately comes out of solution. So you get a perfusion gram, and then it fills the airways and at that point, and then opacifies it. And then as the patient's instructed to breathe, it washes out of the lung based on the ventilation that occurs there. And that's what you can see there. And if this movie projects, I didn't actually test it. Oops. This is just from a paper Scott published in 2005. You can see the images coming in, the lungs opacifying, and then as the patient starts to breathe, they wash out. And you're left with small little areas where there may be some air trapping. This is an asthmatic, and then this is the subject after they gave methacholine to the same subject, you can see the perfusion stays there. There may be some more defects, but now the washout is much slower, and there'll be areas there you'll see there that have these trapped gas. That'll be a relationship with how much ventilation is there. So bronchoconstriction results, and the washout is less. So when we look at our asthmatics after these allergen challenges, right middle lobe, you can see even by CT there's all this edema there. That's not from the amount of saline we instill because the right upper lobe isn't affected. You get a perfusion defect as shown here by the Q. And then after the patient washes out, you can see there's trapped tracer there in the region, and we can actually quantify the amount of defect there. And then by FDG, there's also inflammation that tracks with the EOs. We also measure the airway size directly. And when we've looked at this with the allergic non-asthmatics and allergic asthmatics, interestingly, I would have predicted that we would have big differences. We don't see much difference. They actually also have perfusion defects. They also have ventilation defects. The only thing we really see is the gas fraction. It really drops in the allergic asthmatics, but not in the allergic non-asthmatics. And that really may be a sign of edema. We're still trying to figure out that, but the amount of trapped gas that's there is actually less in the allergic asthmatics, maybe due to the swelling that occurs there. There is some subtle differences in airway size in the allergic non-asthmatics and allergic asthmatics. They certainly see greater swelling of the airway there. And interestingly, the FDG correlation to EOs, which is quite tight, has a different slope here. So are the EOs more metabolically active in one or the other? But the ratio of the EOs to the amount of FDG changes in allergic asthmatics and allergic non-asthmatics. Still trying to sort all this out. Involves stuff a little above my head, so if you invite Scott here, maybe he can explain it better. Let me just show you some of the stuff we've been doing. So you visually can see often in these subjects the constriction that results. This is pre and post here on the left, and then you can see here that this narrows, and the allergic asthmatics tend to have, allergic non-asthmatics, less of a reaction. But we wanted to quantify that, and so we used optical frequency domain, which is a catheter-based, if you can think of it like ultrasound, but uses laser light to form these ultrastructural images. This is what you can see. Here's the catheter, and it's pulling back, and it'll draw images. And you get these nice pictures of the airway with really ultrastructural detail. If I stopped it, you can see the cartilaginous rings coming in, mucus glands, and even get an epithelial border. And with Melissa, we've looked both before and after challenge, looking at epithelial thickness as well as the overall thickness of the mucosa relative to the perimeter. And it's beginning to, we're just starting doing this, but showing some interesting results. At baseline, the asthmatics have thicker airways, which is, I think, certainly consistent maybe with the airway remodeling. So something's different. They both bump, though, in thickness. It's just the asthmatics bump from a higher point to another high point, where the allergic non-asthmatics actually get a nice bump, but they're still now about to where that is. So maybe the asthmatics just start, from whatever reason, at a greater point and then move in. And that's true whether we use mucosal thickness or epithelial thickness. And really interesting, in the allergic asthmatics, the eosinophil response correlates to the mucosal thickness. The more prominent eosinophils you get in, the more thickening of the mucosa that you see there. And what we're really excited about is new work she's doing with polarized light, which allows us to actually pick out the lamina propria here and the airway smooth muscle. Here's the histology showing here that she can now see with this. So this is on pig airways. But we're just hopefully going to be starting fairly soon to look at this and actually be able to measure the airway smooth muscle cell. And she thinks she may even be able to tell, like, contracted muscle versus non-contracted based on the polarization aspects of it. So hopefully be able to give us more structural detail in kind of linking this here. But I don't have an answer for you. So when we compare this, just to summarize, and then I'll have a few minutes for questions here, the allergic asthmatics compared to allergic non-asthmatics, the allergic non-asthmatics seem to have baseline thinner epithelial and mucosal layers. They both thicken up. The allergic asthmatics just end up at a higher standpoint. They have decreased Th2 cytokines and neutrophil active chemokines, which I didn't show you. An increased ratio of Tregs to bulk cells, more suppressive Tregs, more activated Tregs. Which may be one of the reasons they are not getting the physiologic changes you expect. And then finally, if we look at the, it's not popping up. How appropriate that, there we go. Compared to bulk cells, we're seeing an enrichment in Th2 markers and enrichment in T-cell activation. So as I said, this is a huge endeavor. I'm probably not listing everyone here, involving the pulmonary unit, the Center for Immunology, Inflammatory Diseases, and Andy Luster really has been the main person spearheading this whole operation. Daniel Hamelos recruiting a lot of the patients. Work from the Pulmonary Imaging and Bioengineering Lab, which also involves Scott Harris. Melissa Suter doing the OFDI, and lots of funding to do this large operation. So I'll stop there for questions. Thank you. A few minutes early. It's a little bit of a whirlwind.
That was a wonderful presentation. Eye-opening, eye-popping, I would say. Thank you very much. So let's take some questions from the audience, and there may be some submitted from the live webcasting as well. Want to start, Elliot?
Yeah, that's a beautiful body of work. And if I can take you back actually to something you said kind of in the beginning related to STAT6 and blocking, and actually in one set of blocking experiments, actually blocking the epithelial response and the mucus response, and the other actually blocking the allergen response. What do you think that says about the role of STAT6 and compartmentalization of the different types of responses? You know, when you think about asthma and whether asthma is different in different cells.
Yeah, I mean, I think, yeah, so the question is that about the compartmentalization of the STAT6 response, that the airway epithelium, STAT6 seems to mediate the mucus changes, whereas the myeloid cell seems to do more of the inflammation and orchestrating the chemokine receptor. And, you know, it's been an interesting aspect. I think it points to the fundamental property of STAT6 being important for this Th2 type inflammation, and that in different cell types it's doing different things. And we've certainly been very interested, actually Jay Rajgopal has been very interested in the mucus production and what, you know, stimulates that and which stem cells are doing it, and he's found something upstream of, I think, one of the notch, I can't remember exactly, seems to be upstream of that whole response. But I think that there clearly is compartmentalization of this, and, you know, when we went into this, probably naively, we thought, well, the Th2 cells are going to just be more in the allergic asthmatics, and that's what's driving the whole process. I've been really humbled by this to think that it may be the structural cells and epithelial cells that not only mediate the mucus production is important, and maybe airway smooth muscle cells, but that this whole process may be compartmentalized into these different things. I think the Th2 cells, the T-cell response, the inflammation licenses the process, but why some people develop mucus and others don't, and this is going to be related more to these other cell types and these things. That's how I kind of picture it. And it clearly, it's not going to be an easy process to you know, inhibit one aspect of this, right? It's going to be.
I have another question, but
All right.
ask questions.
That was really great.
Oh, thank you.
Thank you so much.
Congratulations on your new job, or condolences, I should say.
Look at you, bro.
Yeah, don't look at me.
So I have two very brief questions. The first is the post-allergen BAL fluid relative to the diluent not only looked cellular, it looked a little pink.
Yeah.
And I'm wondering if you've looked at platelets and vascular permeability in the asthma or the allergic non-asthmatics versus the allergic asthmatics. I was curious about potentially vascular elements contributing to some of this.
There's no question it's a protein rich, and I'm sure we get, you know, vascular leak in these subjects, and you can see it on the CT scan, right? All the edemas there. We haven't looked at differences. The F-gas measure is almost a measure that, at least globally, into that region there, and the allergic asthmatics seem to have more edema and more leak in this situation. And again, speaking to maybe the structural cells as being the important determinant of this aspect. But we haven't looked at total protein levels or, you know, other sort of measures of vascular leak. Some get hemorrhage in this that's more than just the scope trauma. We do our best to, you know, but as you know, a lot of these subjects cough during this thing as best as we can do. But for the most part, they're pretty clean with not much blood in the aspect. But I'm sure there's a leak of protein and the rest that results from this inflammation. It's not, you know, we try to do it to mimic an asthma flare, but it really is more of a hurricane than what you'd see. We try. It's the amount of allergen is supposed to be like what it would be like to spend a day with a cat or something like that. But you're banging it into one segment. We wedge in. It probably washes in and out. Who knows where it goes? But so I think again, it's more important to understand the biology and the immune response than what's necessarily going to be asthma attack in the wild. Let's say.
And the other question relates to resolution.
Yeah.
You expect it.
Yeah.
But in your mirroring modeling, if you knock down the CCR7,
yeah.
I think that's what it is, that you also have effect when you do the adoptive transfer of the Tregs.
Right. They don't leave as fast.
You're looking at the 24 hours after the allergen when you're doing the cellular phenotyping in the human.
In the human, yes.
So I'm just wondering what you might predict were you to look at a 72 hours.
Yeah.
Whether there's a differential resolution to the immunologic response to allergen, and we see a similar upstroke of inflammation, but maybe with those enhanced Tregs, you're seeing maybe they help more quickly. Just curious about that.
Yeah, so actually at the last, or maybe the year before our meeting for this U19, someone brought that up to us and said actually there's old data that allergic non-asthmatics resolve quicker than allergic asthmatics. And so we're only approved for 24 hours. We've talked about, and we have a lot to do with that, but we've talked about looking at 72 hours. And I think the regulatory T-cell would make a lot of sense to look at these late phase, absolutely. So maybe they are just resolving quicker and not, and maybe the remodeling changes or whatever is a persistence of inflammation, right, that causes it versus a reaction that clears and the rest.
Write the renewal.
Yeah, okay, absolutely.
I was curious about the IL-33 receptor.
Which receptor?
The ST2.
The
IL-33.
IL-33, yes.
So definitely those are not neocytes because
they're not. Yeah,
they don't have. They are not lineage negative.
Yeah, they're tetramer positive too. So they are Th2 cells. So they're not the neocytes. We don't see a lot of neocytes in the airway. We've looked. Roshi Afshar and Andy Luster's lab looked for them. And we don't see a lot in the BAL in this response. It's probably a small population. As you know, most of the data is that they live in the tissue. So I'm not saying they're not important. I just don't think a lot come into the lavage fluid, although I think there's one paper that was able to find them. We didn't see them using whatever staining method has been there. So those are the Th2 cells that express that IL-33 receptor, not the neocytes. Yeah.
We have one question from a live webcast listener that I wanted to ask, and it was about the genetic profiles of the cells in the allergic and non-allergic, or allergic non-asthmatic, comparing genetic profiles in the cells.
So we have not looked at genetics with this, and obviously that there may very well likely be a genetic component to this, but we haven't done that. We are starting to profile at least the gene expression, but that may obviously be very different than the genetics. And coming back and looking at this, it's such a small, it's only going to be 60 or so, so I just don't know if we're going to have the power to really look at the genetics behind this, although a larger study could certainly do that. I don't know if Elliot had one more.
I'll do that because I don't want to hold people up.
Well, maybe for the time we'll stop.
Sure.
I do have questions I wanted to ask you, but it was a wonderful presentation. Thank you so much for doing it. Great.